ophthalmology. I am roll number 73. Today, me and my group will be presenting a topic on ophthalmology. So, before we get into the introduction, the anatomy, and everything about the eye, we wanted to start with a case, and then we will build the entire anatomy around the case. So, I'll explain the case and the presentation, and then we'll connect as we go on. A 52-year-old male software engineer, meaning high screen time, presented to the ophthalmology clinic with intermittent blurred vision in the right eye for 6 months, accompanied by mild periorbital headache and difficulty adjusting to dim light. So, a lot of big words. I'll explain term by term. Intermittent blurred vision. Intermittent here means non-periodic or irregular in the right eye for 6 months, accompanied by mild periorbital headache. Periorbital, here the periorbital word means behind the eye. So a tightness or a heavy pressure-like sensation felt behind the eye is also termed as the mild periorbital headache, and difficulty adjusting to dim light. He reported that the symptoms were worse in the evening after prolonged screen exposure over the past 2 weeks. He noticed colored halos around lights and occasional eye redness. So whenever we look through a dirty windshield or a car windshield, we always see rainbows around lights, street lights or lamp lights. Those are what colored halos are. Usually colored halos are a specific sign for one main disease, which we'll talk about in the future. Over the past 2 weeks, he noticed colored halos around lights and occasional eye redness. Past medical history revealed long-standing migraine, hypertension, no history of ocular trauma. Family history revealed that his father had glaucoma diagnosis in his late 60s. On examination, visual acuity, right eye 6/6, left eye 6/6. So visual acuity here means the visual test we usually give at the ophthalmic clinic, where we are told to cover one eye and read alphabets on the wall. That is visual acuity. The 20/20/20 vision is also known as visual acuity. Intraocular pressure, right eye 32 mmHg, left eye 22 mmHg. So the normal ranges of intraocular pressure, or the pressure created by the fluid inside the eye, the vitreal fluid inside the eye, is usually between 10 to 21 mmHg. So in a healthy individual, it is between 14 to 15 mmHg. So we can see that the right eye clearly has excess pressure, where the left eye is almost in the normal range. Anterior chamber moderately shallow in the right eye. Optic disc examination. So in a clinical examination known as fundoscopy, where we examine the fundus part of the eye, we check for the cup disc ratio. So I won't go into detail what a cup and a disc is. We have another 2 slides on fundoscopy. Basically the white shallow part you see, I don't know if people in the back can see, but the white depression you can see in the middle is called the optic cup, and the outer part, the pink layer, is the optic disc. So the diameter ratio of the optic cup to the optic disc is measured in the optic disc examination. It is what we usually check in fundoscopy. So the normal ratio for each eye should come between 0.3 to 0.5, the ratio of this diameters. So here we can see that the right eye has a higher ratio and the left eye has in the normal field. Visual field testing, early nasal step defect in the right eye. Further imaging with optical coverage tomography showed thinning on the retinal nerve fiber layer in the superior quadrant of the right eye. So what the optic disc and optic cup significance is will be explained further, but and the same with the superior quadrant of the right eye. But these are just the main symptoms that were examined in the initial examination of the patient. So here we have the notable symptoms. Intermittent blurred vision I already explained, colored halos, difficulty seeing in low illumination, a mild ocular redness, periorbital headache, reduced contrast to sensitivity. This is also one of the main symptoms of a particular disease, which we will talk about in the future. Earlier visual defects. These symptoms raise suspicion for an atypical or mixed mechanism glaucoma rather than a straightforward presentation. We will discuss the significance of these symptoms and how it really affects the diagnosis or differential diagnosis in the further. Right now we will discuss the anatomy of the eye and how these are abnormal and what the normal really looks like. So for the further part.
वो मैं क्यों नहीं
बोल
Good morning, everybody. Myself Mohammad Haziq, roll number 70. Today, me and my colleague are going to present seminar on the topic.
Be
that is-
loud and hold it close.
Today, me and my colleague are going to present seminar on the topic that is eyeball. The topic to be covered in this session will be first one is introduction and second is anatomy of the eye, in which spatial anatomy, eyeball, which include sclera, uvea, retina, cornea, optic media, and optic nerve, and extraocular muscle. The third one is optic pathway and lesion in the optic pathway. Fourth one is case, and fifth one is recent and advancement in the ophthalmology treatment. Sixth one is conclusion. As you know, the eye is the organ of vision that allows us to see the surrounding world. It detects light, color, shape, and movement, and send visual information to the brain through optic nerve. The eye works like a camera by focusing light on the retina, which convert light into the nerve signal. Eye are located in the bony orbit, and its movement are facilitated by 6 extraocular muscles. As you can see in this diagram, this is the left eye, which are present in the bony orbit. This is zygomatic bone and maxilla. The fat tissues are present, which are surround the eyeball, also called as cushion tissue, which prevent the injury to the eyeball. There are 6 extraocular muscles which facilitate the movement of the eyeball, in which they are superior rectus, inferior rectus, medial rectus, and lateral rectus, superior oblique and inferior oblique. This is the lacrimal gland which are present lateral to the eyeball, which help in the releasing of the tear. Tear help in the nourishing the corneal layer and prevent the infection to the eyeball. The main supply of the eyeball is through the ophthalmic artery, which is branch of the internal carotid artery. The vein is drained through the optic vein, which is drained into the cavernous sinus through supraorbital fissure. The sensory information of the eyeball are carried out through sensory information of the eyeball are carried out through sensory information of the eyeball are carried out by optic nerve, which is second cranial nerve, and ophthalmic branch of the trigeminal nerve.
Google Chrome. You can
sensory information of the eyeball are carried out by spread out by optic nerve, which is second cranial nerve, and ophthalmic branch of the trigeminal nerve. There are 3 cranial nerves which are responsible for the motor functioning of the eye. They include oculomotor nerve, trochlear nerve, and abducens nerve. Thank you. Next topic will be covered by the Asal.
Hello and good morning everyone. Myself as Savarini Marker, roll number 75. Today I'm gonna speak about the spatial anatomy of the eye. As we all of us know that the eye is a specialized sensory organ.
कानात लगा ते दुसरा माईक दे असं घालायचं गोल हां राईट.
Eye is the specialized sensory organ responsible for the vision. Basically, it performs the functions.
आवाज येत नाही ना स्पीकरवरून आवाज येतोय का तुझा? हॅलो हॅलो.
इसी को डाल दो.
हॅलो हॅलो.
As we all of us know that the eye is the specialized sensory organ responsible for the vision. It performs the following functions. It receives light from the environment, converts light into the impulses, and then it sends visual information to the brain through the optic nerve. It is basically located in the bony orbit of the skull. It enables visual perception, depth, color recognition, and spatial awareness. Now, let us see what this spatial anatomy of the eye means. Basically, it refers to the 3D arrangement and relationship of structures within the eye. There are 3 major structural layers, namely fibrous layer, vascular layer, and the neural layer. Fibrous layer includes sclera and cornea. Vascular layer includes choroid, ciliary body, and iris. And neural layer consists of retina. Now, the basic structural organization of the eye. It includes 3 main chambers, namely anterior, posterior, and the vitreous chamber. Anterior chamber is located between the cornea and iris. Posterior chamber is located between the iris and lens, and the vitreous chamber is located between the lens and the retina. Important components of the eye include lens, retina, and optic nerve. Lens focuses the light onto retina. Retina contains of photoreceptors, namely rods and bones, and optic nerve carries visual signals to the brain. Now, the significance of this organization is that it allows proper image formation and vision. Thank you.
Good morning everyone. My name is Ajay, roll number 66. My topic is fibrous layer. The outer fibrous layer is a tough protective outer covering. It is mainly made up of 2 parts, that is sclera and cornea. First, we have study about sclera. Sclera is a white opaque part of the eyes which covers about posterior 5/6 of the eyeball. It is mainly composed of dense connective tissue which makes it strong and resistant. Function of sclera. It protects internal structures, maintain shape of the eyeball, and provide attachment to extraocular muscles which helps in the movement of the eyeball. Now let's talk about cornea. Cornea is a transparent anterior 1/6 part of the fibrous layer of the eyeball. It is avascular, that is there is no blood supply present in it. It is highly sensitive. Damage can cause severe pain. It is supplied by ophthalmic branch of the trigeminal nerve. There is no lymphatic system is present in it, which provides immune response, which is responsible for low graft rejection. Now let's talk about clinical significance of cornea. Now let's talk about clinical significance of cornea. Loss of transparency due to any injuries, inflammation, or edema results into impaired vision or blindness. Cornea is highly sensitive structure. Damages causes severe pain and triggers corneal reflex. It is common site for infections such as keratitis, which is the inflammation of the cornea, and ulcer, which can affect the vision. Corneal transplantation, which is known as keratoplasty, is possible due to avascular nature. There is no blood supply, which minimize the graft rejection rate. Thank you so much. morning everyone, my name is Dhamchand Meena, roll number 67. UVL tract is the middle vascular layer of the eye located between the sclera and retina. This layer contains blood vessels and provide nutrition to the eye. The parts of UVL tract: choroid, second ciliary body and iris. Choroid is a thin pigmented layer which separates the posterior part of the sclera from the retina. Posteriorly, it is perforated by the optic nerve to which is firmly attached. High vascular layer supply oxygen and nutrients mainly to the outer layer of the retina. Second, ciliary body. Ciliary body has two parts: pars pellicata anterior part and pars plana posterior part. The ciliary body is triangular in cross section. It is thick in front and thin behind. The scleral surface of this body contains the ciliary muscles. It continues anteriorly with the iris and posteriorly with the choroid. It suspends the lens and helps it accommodation of near vision. Iris. This is the anterior part of the uveal tract. This iris is the colored circular structure of the eye that lies in front of the lens and behind the cornea. The two types of muscle of the eye: sphincter pupillae circular muscle and dilator pupillae radial muscle. It controls the eye. It controls the amount of the light entering the eye and thus behave like a adjustable diaphragm.
एंटीरियर पार्ट पोस्टीरियर पार्ट उसका कुछ मसल अटैचमेंट मसल का कुछ कनेक्शन है तो या लेंस का सस्पेंशन ठीक है.
Clinical anatomy. While looking at infinite warfare, the light rays run parallel. Ciliary muscles relax and suspension ligament is tense and lens is flat. While reading a book, the ciliary muscle contract and suspension ligament is relaxed, marking the lens more convex.
मेकिंग पाहिजे.
Good morning everyone, my name is Mandari Moiresh, my roll number is 64. Today I am going to present a short seminar on retina and optic media. Optic media is the transparent medium through which light passes to reach the retina. It consists of aqueous humor lens and vitreous humor and cornea. They reflect light to focus it precisely on the retina. The retina is the innermost light sensitive layer of eye lining the back of the eyeball. It functions as the camera film, converting light into neural signals. Microscopic structures and functions of retina: photoreceptors, rods more than 120 million, highly sensitive to light, responsible for peripheral and night vision, cones 6 to 7 million, responsible for color vision and high acuity central vision, concentrated in the macula. Neural transmission: light passes through the layers to reach rods and cones, which synapse with bipolar cells, then ganglion cells whose axons form the optic nerve. This is diagram. Regional anatomy and clinical significance: macular lutea, central region responsible for sharp detailed vision, contains the fovea which has the highest density of cones. Optic disc, also called as blind spot, the site where ganglion cell axons exit the eye to form the optic nerve. It contains no photoreceptors. Ora serrata, the jagged anterior edge of retina marking its junction with the ciliary body. Clinical relevance: the retinal pigment epithelium supports photoreceptors and disruptions can lead to conditions like macular degeneration and retinal detachment. Next is Krishnamani.
Good afternoon everyone, myself Krishna Vani, roll number 65. I am going to present a seminar on layers of retina and retinal microanatomy and the fundoscopy. So layers of retina. There are 10 layers of retina as outer pigment layer, rods and cones, external limiting membrane, outer nuclear, outer plexiform, inner nuclear, inner plexiform, ganglion cell layer, nerve fiber, inner limiting membrane. And under the microscope it looks like this. So the photoreceptors, rods, which is used for the dim light vision, cones for the color and visual acuity, located in the outer retina. The retinal pigment epithelium, which is a pigment cell layer, absorbs light and supports the photoreceptors. Neural connections. Bipolar cell connect photoreceptor to the ganglion cells. The fundoscopy, also known as the ophthalmoscopy. The fundoscopy is examination of the interior of the eye, mainly the retina, macula, and the optic disc. The types of fundoscopy, there are two types of fundoscopy, as direct ophthalmoscopy and indirect ophthalmoscopy. Direct ophthalmoscopy, there is upright image, high magnification, and small field of view, mainly for the optic disc. Whereas indirect ophthalmoscopy, there is an inverted image, wider field of view, and mainly used for the peripheral retina. Indications are diabetic retinopathy, hypertensive retinopathy, papilledema, glaucoma, retina detachment. Equipment used are direct ophthalmoscope, indirect ophthalmoscope, slit lamp with fundus lens. Procedure and clinical findings of the ophthalmoscopy. Procedure for the direct ophthalmoscopy. Darken the room, ask the patient to fix gauge and distance object. Use right eye for patient's right eye and vice versa for similar. Approach at 15-degree angle, examine the red reflex, optic disc, vessels and macula. The red reflex is nothing but the red or brown deflection when there is light shown onto the eye. Normal fundus appearance. Optic disc is pink, well-defined margins. Curve to the disc ratio is nearly less than 0.4. Macula, dark with foveal reflex. And vessels are normal. Artery to vein ratio is 2:3. Abnormal findings are papilledema, where the blood disc margins. Diabetic retinopathy, where are microaneurysms, hemorrhages. Hypertensive retinopathy, it is AB nicking, cotton wool spots. Glaucoma, increased curve to disc ratio. Limitations are required patient's cooperation, media capacity, that example cataract, where there is hindered vision, and small field indirect ophthalmoscopy. Thank you.
Good afternoon, everybody. My name is Pranav Mogle. Today I am going to present a short seminar on the topic aqueous chambers. This is the build-up of the aqueous rumor. As you can see in the first diagram, there is a part cornea, then lens, then iris.
स्टार and star
स्टारला प्रेस
star खाली है.
As we can see in the above diagram, first is the cornea, then is the iris, and along with the lens and the ciliary body and muscles. And in our below diagram, there is a trabecular network, meshwork. So, aqueous chamber. Aqueous chamber of the eye is the fluid-filled space located at the front, containing aqueous humor. The aqueous humor is the thin and watery liquid. It is divided into anterior chamber and the posterior chamber. It provides the nutrients to the eyeball and it maintains the eye pressure. Anterior chamber. Anterior chamber is the space between cornea and the iris. It is filled with the aqueous humor. Anterior boundary of the aqueous chamber, anterior chamber is made by the posterior surface of the cornea, and the posterior boundary is formed by the anterior surface of the iris and the lens, and at the periphery it is formed by the iridocorneal angle. So posterior chamber. Posterior chamber is the narrow space behind iris and the in front of the lens. It is also filled with the aqueous humor. It anteriorly covers posterior surface of the iris and the posteriorly anterior surface of the lens, and the laterally by the ciliary body. For formation and the drainage of the aqueous humor. Aqueous humor is produced by the ciliary process. It secreted into the posterior chamber and then flows through the pupil into the anterior chamber. It drains through the trabecular meshwork. Then the canal of Schlemm and then the epic veins. Function and the applied anatomy of the aqueous humor. It maintains the intraocular pressure and provides nutrition to the cornea and the lens. It removes metabolic waste. It causes the glaucoma due to the impaired drainage of the aqueous humor. And angle closure due to glaucoma and the hyphema. Glaucoma is the condition in which it is a condition of eye. It damages the optic nerve, often due to the abnormal drainage. And hyphema is the accumulation of blood into the anterior chamber. It is often due to the forcible trauma.
Morning one and all. Myself Mahesh Gudfare, roll number 63. Today I will present about extraocular muscles. Extraocular muscles are the skeletal muscles which are used for the movement of eyeball without changing the body posture. If अगर हमें आजू बाजू का देखना मतलब बॉडी को न हिलाते हुए आजू बाजू का देखने के लिए हम एक्स्ट्राओकुलर मसल्स का इस्तेमाल होता है. और there are two types of extraocular muscles. Voluntary muscles which are in our control and involuntary muscles which are not in our control.
See, involuntary muscles, extraocular, ocular muscles. I can extraocular muscles. खाली you have to say ocular muscle. जो involuntary रहते हैं उसमें से आधे तो अंदर they are not all extraocular.
Voluntary muscles. There are 4 recti and 2 superior two oblique muscles and 1 levator palpebrae superioris. 4 recti are superior rectus, medial rectus, lateral rectus, and inferior rectus, and superior oblique and inferior oblique. And involuntary muscles are there are 3 involuntary muscles: superior tarsal, which is also known as Muller's muscle, and inferior tarsal and orbitalis. The origin of rectus muscles. All the recti muscles are originated from the annular zeme, which is present in the middle part of superior orbital fissure, and all the recti muscles are inserted proximal to sternoccorneal junction, sclerocorneal junction. The actions of extraocular muscles are like this way. The superior rectus causes the elevation and adduction as well as intorsion of the eyeball, and inferior rectus is just opposite to the superior rectus, which causes the depression of eyeball, adduction of eyeball, and extorsion. And medial rectus, as the name suggests, the medial rectus means it pulls the eyeball towards the medial side, and the lateral rectus pulls the eyeball towards the lateral side. And inferior oblique and superior oblique, they were opposite to their name. Means inferior oblique causes the elevation of eyeball and abduction of eyeball and extorsion of eyeball, while superior oblique causes the depression of eyeball, abduction of eyeball, and extorsion of eyeball. Then levator palpebrae superioris. The origin of levator palpebrae superioris is from the lesser wing of sphenoid at the orbital apex. As the levator palpebrae superioris comes forward, it divides into the 3 laminae: upper lamina, middle lamina, and inferior lamina. Upper lamina is skeletal muscle part, and the middle lamina is the smooth muscle, and the inferior lamina is the connective tissue. Upper lamina insertion of upper lamina is inserted on the
skin of upper eyelid, and middle lamina. Middle lamina is inserted on the superior tarsal plate, and the inferior lamina is inserted on superior conjunctival fornix. The nerve supply. The upper lamina is supplied by the third nerve, oculomotor nerve, while the other two are supplied by the postganglionic sympathetic fibers of superior cervical ganglion. And the action, overall the action of levator palpebrae superioris is the elevation of eyeball, elevation of upper lid. And there is applied anatomy. If there is a damage to only third nerve, then there will be partial dropping of upper eyelid. But if there is a damage to the oculomotor nerve as well as the sympathetic postganglionic sympathetic fibers, then there will be the complete complete dropping of eyelid. The blood supply of ocular muscles. The first of all, the internal carotid artery. Internal carotid artery gives the branches ophthalmic artery, and the branches of ophthalmic artery supplies the all the ocular muscles like supratrochlear, supraorbital, and lacrimal artery. And the venous drainage is from the supratrochlear vein, supraorbital vein, superior ophthalmic, inferior ophthalmic, and the facial vein. The nerve supply to the ocular muscles. All the ocular muscles are supplied by the third cranial nerve, oculomotor nerve, except the SO4 and LR6. Superior oblique, which is supplied by the fourth cranial nerve, and lateral rectus, which is supplied by the sixth cranial nerve. And the optic nerve is also called as second cranial nerve. The course of optic nerve. It begins from the retina and goes to the lateral geniculate body. From retinal ganglion cells, as Krishna said, there it leaves the eye disc, eyeball, giving a blind spot. Then it passes through the orbit optic canal, meets the opposite optic nerve at optic chiasma, and continues as the optic tract and goes into the lateral geniculate body of thalamus. The function of optic nerve. Optic nerve is purely sensory nerve which carries the sensation from retina to the brain. And the blood supply of optic nerve is the central artery of retina and the branches of ophthalmic artery. Thank you.
Good afternoon, everybody. Myself Mrunali Mughal, roll number 72, and my today's topic for seminar is optic pathway. The route that helps us in traveling the visual impulses that are generated at the site of the eyeball to the brain is actually the optic pathway. The various components of optic pathway I have mentioned here, but before actually getting into the optic pathway, it is very important to understand what we actually pursue and how we pursue. That is basically I am talking about the visual field. So visual field is that particular region of the external world which we pursue when we keep our head fixed and without having any movements of the head as well as of the eyes. So that particular region is actually the visual field. As you can clearly see in this diagram, there is certain region which is actually common for both the eyes, and that particular type of vision is termed as the binocular vision. On the other hand, this peripheral region, what we can observe here, is made for that particular side of the eye only, and that type of vision is your monocular vision. Now further, for making it more easy, we have actually divided the retina as well as your visual field into 4 quadrants. Ma'am, can I advance you?
Lightly. Rahul.
So here I will be considering only one side because the same is going to be interpreted on the other side. So let's consider this is your any side of the field of vision. And further this on the lower side I am drawing how we pursue it on the retina. So for the east we have divided the visual field as well as the retinal field into 4 quadrants. This is your nasal side and this is your temporal side. And also further we have divided into a superior and inferior one. This is your superior and this one is your inferior. Now first we will name the quadrants. This particular quadrant is located on the nasal side as well as on the superior. So this is your superior nasal quadrant. And further this one will be your inferior nasal because it is located on the nasal side as well as on the inferior aspect. The same goes on this side, on the superior one, and on the temporal side, the superior temporal. And this one will be your inferior temporal. Now, when this we perceive on the retina, this sides.
T.
टेन निकाला है ना वहाँ पे टी निकालो
Yeah, sorry. Now, when we perceive this on the retina, these quadrants get completely changed. What I mean to say is, the nasal will become temporal here and vice versa, that is temporal will become nasal, and along with that the superior one will be interpreted as the inferior and the inferior will become the superior. That is basically, let's consider one quadrant. This is the superior nasal quadrant, but this will be interpreted as the inferior temporal quadrant. So this superior will change to inferior, and apart from that this nasal will also become temporal. Also similar will be with the others, that is the superior temporal will become the inferior nasal, and this inferior nasal will become superior temporal. I should have written this like that, actually it will be more easier. Inferior, sorry?
वरची डायग्राम खाली रिपीट व्हायला.
Exactly. This should become, this will be here, inferior nasal. And here we will be perceiving the inferior nasal part, inferior temporal part. So this is how we interpret. So what we can actually observe here is the image that we are perceiving on the retina is completely opposite of what we actually see. That is basically, it is perceived completely opposite. I have got a very nice image to explain that. So that is how we actually perceive the image on the retina. It is completely opposite of what is actually the object, and however when we actually see it, it is interpreted erect. That is because of the association areas basically which are located in the region 18 and 19 of the cortex that actually help us in perceiving the image in an erect manner, the image how actually it is. Now let's actually get into the visual pathway. So the visual pathway starts as the light rays falls on the retinal layer. So the very first layer that gets excited is the layers of the rods and cones. So this is your right side of the eye, this is your left side eye. We are again divided into two parts, that is the nasal and the temporal. Nasal and the temporal. So the very first layer that is to be excited is the layer of the rods and cones. So these are your rods and cones. The next layer to be excited is the layer of the bipolar cells. These bipolar cells are specifically located in the inner nuclear layer of the retina. There are only 10 layers of the retina. So these bipolar layers are located on the inner retinal layer. Sorry, the inner nuclear layer. Now further, the next layer to get excited is the layer of the ganglion cells. Now further, the fibers of these ganglion cells will come together and result in the formation of the optic nerve, which is basically your second cranial nerve. Now here what happens is the fibers of the nasal side in the optic nerve will cross each other. On the other hand, the fibers on the temporal side will not cross each other. and as a result, a crossing will be formed here. This is termed as your optic chiasma. On the other hand, these temporal fibers will not cross each other and therefore will be passed on to the same side. Further, this fibers here, this is termed as your tract, optic tract. This was your optic nerve. Further, this optic tract is received by your lateral geniculate body, which is nothing but the specific nucleus of the thalamus. And further, the fibers originating from this lateral geniculate body will form your geniculocalcanean tract, which is commonly known as optic radiation. And actually, before originating in the form of optic radiation, these fibers will pass from the internal capsule. Specifically speaking, it is the retrolentiform part of the internal capsule. And further, these fibers will be received by your brain cortex, that is basically your area number 17. Now, majority of the fibers will directly pass into the area number 17, but certain fibers that originate actually from the lateral aspect of the lateral geniculate body, they will form a loop on the inferior horn of the lateral ventricle in the temporal lobe. That loop is termed as the Mayer's loop, and then further they pass posteriorly into the optic lobe at the area number 17. So this whole is your optic pathway. That is, we begin with the retina, then comes your optic nerve, the optic chiasma, the optic tract, then the lateral geniculate body, then the optic radiations of the geniculocalcanean tract, and finally your optic cortex, that is area number 17. The same thing I have added on this next slide. Now here this diagram, here it is so good because it is not only representing the optic pathway, but it is also representing the various quadrants that are pursued. Now here the quadrants are shown in the form of macular region and the peripheral region. Macula is that particular region in the retina which where the vision is more accurate because of the more density of the rods and the cone cells. Now here you can see the same is shown, that is the nasal fibers are crossing but the temporal fibers will pass on to the same side, and therefore there is kind of partial crossing occurring in the optic chiasma, and further the optic tract, which consists of the fibers, the cross nasal fibers and the same side temporal fibers, and finally the calcarine sulcus in the optic in the occipital lobe, which is basically optic cortex. Thank you.
Good morning, myself Mohammad Faisal. I will be talking about the lesions in the optic tract. So first lesion is in the optic nerve, this one. So it will cause a monoocular blindness. One eye will be completely blind and the other eye will have normal vision. In the second, we will have the lesion in the proximal part of the optic chiasma. So there will be monoocular blindness in one side, like the previous lesion, and then the nasal fibers from this side will also be affected, causing blindness in the temporal visual field. But if the person is lucky, only the inferior fibers will be affected and superior vision will be lost on the second eye. The third one will be the bitemporal hemianopia, which was in the exam. So it occurs due to the pituitary adenoma. So it will cause a deflection of the lesion in the nasal fibers from both the sides, causing bitemporal vision loss. Fourth one will be the lateral chiasma. The lesion will be in the lateral part of the chiasma. This is a very rare lesion because for this the lesion has to be two lesions and only both the sides of the chiasma. So only binasal ipsilateral lesion will visual field will be lost. Fifth one will be the optic tract. So what will happen is the temporal fibers from this side and nasal fibers from this side will be affected, causing a contralateral homonymous hemianopia. So visual field will be lost from this side of the Sixth one will be the lateral geniculate body, causing visual same as the fifth one. There will be loss of the vision on the left side, right side. Seventh one will be optic radiation going to the temporal lobe, which will be the inferior fibers, causing a loss of the left side and the superior visual field. Eighth one will be the parietal lobe radiation, and it will cause the lesions in superior fibers of the optic tract, causing visual field loss in the inferior side. Ninth one will be the combination of both the seventh and eighth. So high myopia is present. Then tenth one will be, so tenth one, when the visual cortex is supplied by posterior cerebral artery and the middle cerebral artery collaterals. So when there is a lesion in the middle cerebral artery, posterior cerebral artery, middle cerebral artery gives the collaterals, due to which the macular lesion, macular visual field is spared. So there will be sparing of the macula and peripheral loss in the opposite left side, right side. Then in the 11th one there will be macular scotoma, and 12th will be also the macular scotoma because of the visual macular fibers will be affected, causing macular loss of visual. Thank you.
Good afternoon everyone, myself Mohammad Ali Rizvi, and we are almost done with the anatomical part and functional component, various components which will help us to understand the case much better. So let's get to the diagnosis of the case. For understanding the diagnosis of the case, let's first enumerate the symptoms. Of the case, that is the shallow anterior chamber, hallux formation, intermittent blood vision, increased intraocular pressure, along with increased Cup-Zix ratio, which suggests the progressive nerve damage, optic nerve damage. So the first diagnosis which we reach to is the most common type of glaucoma, that is primary open-angle glaucoma. So what do we mean by the angle right here is in the primary open-angle glaucoma, the angle we are talking about is the angle between the cornea and ear. So this is the cornea and this one is the iris. So we are talking about the angle between cornea and the iris. So in primary open-angle glaucoma, the trabecular mesh network which is present in the junction of the cornea and the iris is blocked, and while the angle remains normal or open, which suggests the primary open-angle glaucoma. While if the angle of the iris is reduced, angle is reduced, with the blockage of the trabecular meshwork, it suggests the angle closure glaucoma. So the symptoms which help us, which suggest that it's open-angle glaucoma, is the intraocular pressure, increased intraocular pressure, increased Cup-Zix ratio, which suggests progressive optic nerve damage, and peripheral video loss. However, the intermittent symptoms such as shallow anterior chamber and the intermittent blood vision, which suggests that there could be an additional mechanism or any additional disease responsible with it. Second is the primary angle closure glaucoma. It is possible due to the shallow anterior chamber, halo vision, and increased intraocular pressure, but the patient lacked any acute severe pain, which suggests that the patient might be having chronic cause. as the patient have been suffering from this problem since last 6 months. Primary pigmentary glaucoma. It is also a type of open angle glaucoma. In this, the pigmented, as we will have to rule pigmentary glaucoma as the patient, there was no signs of pigmental dispersion. It's pigmental dispersion is when the pigment granules of the iris falls back in the trabecular meshwork, leading to its blockage, which was absent in the patient. So pigmentary glaucoma needs to be ruled out. While the secondary glaucoma, steroid induced, also need to be ruled out as the patient suggests no history of steroid use. So the diagnosis most likely would be the mixed symptoms of primary open angle glaucoma along with angle closure glaucoma. So the final diagnosis is the mixed mechanism glaucoma, primary open angle with the symptoms of primary open angle glaucoma with the additional symptoms of angle closure glaucoma, which gives the answer of the both as the visual field defect, which is early glaucoma change and raised intraocular pressure, which suggests glaucoma's pathology, and increased curvature ratio, which suggests the optic nerve damage. These are the symptoms of open angle glaucoma, while the shallow anterior chamber, hallus, and intermittent blurred vision are the symptoms of angle closure glaucoma. While the, as mentioned earlier, the patient is suffering from these problems since past 6 months, so the acute angle closure needs to be ruled out, so it's suggesting its chronic course. So now we are done with the diagnosis of the case. The remaining is the treatment, which will carry on by the Neil Shah. Thank you.
Good afternoon, everyone. I am Neil Shah and I will be talking about the treatment of glaucoma. Glaucoma as a whole doesn't have any specific cure. However, there is treatment available to improve or maintain the quality of life. The treatment mainly focuses on reducing the intraocular pressure and preventing any further damage to the optic nerve or preventing the loss of visual field. Different types of glaucoma will have different treatments as they have different causes. Let's start with primary open angle glaucoma. The main treatment is to reduce intraocular pressure in this type of glaucoma, and the most preferred treatment is medical therapy, starting with prostaglandins, which increase the uveo spiral after decreasing the IOP. Next are carbonic anhydrase inhibitors and beta blockers, both of which work on similar mechanism of decreasing the aqueous humor production. If medical therapy doesn't work or is slow to work, we can go for laser therapy. In laser therapy, a small laser is used to improve the drainage of the tissue, which is located at the angle where the iris and the cornea meet. And lastly, there are surgical treatments, which includes introducing drainage devices or minimally invasive glaucoma surgery, which one of us will be dealing with later. In case of primary angle closure glaucoma, if it's an acute case, that is, if the progression is very fast, it becomes a medical emergency and it has to be treated as soon as possible with laser therapy, which is supplemented with drug therapy. The case which we picked out was a case of mixed mechanism glaucoma, and therefore it is important for us to treat both the components, that is, we have to reduce intraocular pressure and at the same time prevent further angle closure. So the treatment to decrease IOP will be medical therapy as said, and to prevent further angle closure will be laser therapy. Next are the side effects. Since we are administrating drugs, it is important to know the side effects which they can cause. Prostaglandin can cause red eye, beta blockers can cause bradycardia with hypertension, and laser iridotomy. This one is important because it may cause glare disturbances, which has to be addressed. Coming to why we chose this case, in the future when we learn about glaucoma and its type, it is most likely that we'll only learn about the pure cases of glaucoma. However, on field in real life, there may be cases of mixed mechanism glaucoma which can be a bit harder to diagnose. And if we miss the diagnosis by a certain extent, for example, in this case, had we missed that this intermittent progression of the angle closure glaucoma, like, the patient would have suffered from complete or partial visual field loss, which we definitely do not want. Therefore, the early detection is important, and we have to go through all the 3 steps every time. It includes intraocular pressure measurement, the optic nerve assessment, and visual field testing. Next up, I'll call over Sujit to go with the recent advancement in ocular function.
Good afternoon, everyone. My name is Sujit Makdum, roll number 62. As the many advancements have occurred in the imaging and surgical techniques, this results into the advancements in ophthalmological techniques. This mainly focus on early diagnosis and minimal invasive surgery. First is advances in cataract surgery. Femtosecond laser assisted cataract surgery. As the name suggests, femtosecond laser is used instead of manual instruments, and this improves precision, cause less trauma, and cause faster recovery. Used in corneal incision, capsulotomy, and lens fragmentation. Advances in glaucoma treatment, minimal invasive glaucoma surgery, for example, eye stent implantation. It improves the drainage of aqueous humor and reduces intraocular pressure. Long-acting drug delivery, injectable or implantable drugs provide sustained release of medication. Then it can replace the daily eye drops. Advances in retinal disease treatment. This is anti-vascular endothelial growth factor therapy, which reduces the abnormal growth of blood vessels and used in the age-related macular degeneration, diabetic macular edema, retinal vein occlusion. Thank you.
अलीकडची स्लाइड दाखवते ते ह्युमरसली झालं ना रे.
Good afternoon everyone. Myself Mayank, roll number 61. I am here to conclude this session. Eyes has three layers: outer fibrous sclera, middle vascular uvea, and inner neural layer retina. Vision depends on the light refraction and neural transmission of the image to the brain. Optic pathway connect eye to the brain. Modern ophthalmology focus mainly on laser, microsurgery, and regenerative therapy. Lesions which occur in optic pathway can cause visual defects. Thank you.